you very much for having me here. I'm just going to talk a little bit about what we do as radiologists. We're sort of the eyes of our breast cancer program at the hospital. I have nothing to disclose. So, what is the most common type of female cancer? And I realize I probably can't get answers in this setting, but breast is the most common type of cancer. It affects 1 in 8 women, as we all know. And the American Cancer Society estimates are that it's going to affect around 300,000 people this year. Additionally, lung is the next most common cancer, and it is half at best as common as breast cancer. Breast cancer also is disproportionately devastating to minorities. There's a 41% higher mortality rate amongst African American women. And we'll talk a little bit about that in a minute. That's the bad news. But the good news is we do an excellent job of diagnosing and treating breast cancer. And even though it's the most common cancer, it is not the most common cause of cancer death. Death rates have steadily decreased since 1989. And that is due to early detection, and it's also due to better treatments. So this slide doesn't show up as well, but it is from the American Cancer Society, and it shows that early stage breast cancer, meaning it's small and not outside of the breast, has about a 99% survival rate, which is incredible. So, what we do in radiology centers around mammograms. And screening mammo is the mammo that everyone has, hopefully once a year, starting at age 40. And we take two views of each breast and we look at those to make sure that there's been no changes, that there's nothing that we're worried about. They're called the craniocaudal and the medial lateral oblique view, and I'm going to show those to you in just a minute. It this has proven to find lots of cancers in patients that they would have not felt for years. At Emory, we also add something called tomosynthesis, and a lot of hospitals are adding this in now. It's essentially a 3D mammogram. Like it's if you had a book, and a mammogram would be more like looking at the cover of the book, but tomosynthesis allows you to flip through the pages, so you're able to see within the breast, and it decreases the number of people that we call back, and it also increases our cancer detection, particularly invasive cancers. So it's a win-win. And this is a screening mammogram. This is the MLO view, and this is towards the head, towards the feet, and this is the craniocaudal view, and this is lateral and medial. And we get these views on every patient on both breasts when they come in. So this is someone getting a mammogram, and I know you're thinking to yourself, why on earth would I want to do this? It's uncomfortable, and it's just something I'd rather avoid. But this is why. Because when you find a mass on a screening mammogram and you're having a screening mammogram every year, this is the general size of your breast cancer. So a little over a centimeter. But if you by chance find a breast mass in your breast and then you come in for us to look at it, it's 3.6 centimeters. So when you're talking about a breast cancer this size, you're much more likely to have it only confined to the breast and have that 99% survival that we were just talking about. So this is a picture of tomosynthesis and why it's so helpful. So this patient has dense breast tissue, and when you look inferiorly right here, this area doesn't really stand out to me, and it probably wouldn't stand out to a lot of people. But once you put tomosynthesis on, you can see all these lines coming out from it, and that indicates to us that that's something we need to be worried about. So this is a picture. This is the exact same breast, just put one on one side, or put this regular view on this side and this tomosynthesis view on this side. And right here is where I want you to look, and then I'm going to show you a better picture of it in a minute. You can't see it at all with the regular view. But right here is a mass that's coming in and out of profile, and you can see lines coming in, into, and out of it. We'll flip to the next picture where you can see it better because it's bigger. And you can see right here, this is the mass right here with the lines going in and out of it. We cannot see that without tomosynthesis. So, a diagnostic mammogram, I would imagine that many people in the audience have had a diagnostic mammogram. And when you have one of those, it's because we saw something on your screen that we just need to get a better look at. So, we need to do some extra pictures, maybe an ultrasound, just to kind of figure out what's going on. Additionally, if you come in with a complaint, you have pain, you have a palpable mass, you have your nipples looking inverted, you have discharge, things like that, you come to us and we try to figure out why. So this is a picture from what we do with diagnostic mammo. We press on an area with a spot compression view, and we're looking to make sure that that tissue will disperse out. And when it doesn't, then we're worried. So we can see this is a mass. This is all tissue out here. And when we press on it, the mass is still there and it's still dense. And so we know that patient needs to have an ultrasound. This is a picture of calcifications. They're very difficult to see right here. But in here, we got an extra picture called magnification views to look at them very closely. And this tells us that they're vary in size and shape, and we want to do a biopsy. There's other types of calcifications that we get these extra pictures on, and we say, yeah, they're fine. But they're very, very helpful to be able to have these. An ultrasound is something that I would imagine a lot of people have had. So ultrasound is very different than mammo. It actually uses sound waves to evaluate things. It tells us if something is just a simple cyst. It helps us look at lymph nodes. It helps us know if we should be worried about something and wanting to biopsy it because it's cancer. And it just adds to our exam. So mammo finds things, and ultrasound's sort of a problem solver for us. So this is what a suspicious mass looks like by ultrasound. Oftentimes they're taller than wide, they're irregular. This one has an angular margin, and it's lumpy bumpy kind of within the texture. This is something that tells us we need to be worried. So we use ultrasound to figure that out. For this patient, this is a simple cyst. It's completely black, it's flat. We know you're gone. You can come back to screen in a year. There's nothing we need to do. This is fine. And then we look at this mass and we're kind of somewhere in between. This looks like a benign mass. It has all of these things about it that tell us that it's not cancer. It's flat, it's smooth, it's oval, but it's still not a cyst. So we probably would follow this up and just watch it closely, but know that it's almost certainly benign. And then we can do biopsies under all modalities. We can do it under mammo, which is the stereo biopsy. We can do it under ultrasound. And this is just a picture of a mass with a needle going through it. With ultrasound, it's very nice to be able to see things in real time. So we can just take a sample in real time. And this, we also do localizations with ultrasound. This is just a localization wire going through something. And we can do something called Savvy Scouts, which is like placing a little radar detector chip in your breast. And we place that, and then that helps to guide the surgeons. So, MRI is a relatively new technique with breast imaging. And it is done to evaluate things that we may not be able to see with a mammogram. So it's a powerful magnet, and somebody will inject a patient with contrast, and we use that magnet to kind of see what the contrast is doing. So cancers like to take up contrast really quickly and let go of it really quickly, and the MRI captures that and lets us know where that's happening. And so then we know the areas that we need to be worried about. It's not limited. Breast density doesn't matter how dense your breast tissue is. We're looking at contrast enhancement. So it's cancer dynamics that we look at. So it's not limited by breast density. And that's a huge thing for us. Additionally, we can see implant ruptures and things like that. We use them often to stage cancers and to screen women that are high risk. This is a picture of an MRI, and this area is abnormal. So this area has fast contrast enhancement, and it's letting go of contrast relatively quickly. And you can see it's very different from the rest of the breast tissue. And so we know from here to the nipple is not what we want to see. Additionally, here's another mass seen by this MRI. We can see that has a little area of necrosis centrally, but you can easily see that this mass is taking up contrast differently than the rest of the breast. So this is a patient that had breast cancer, and we were wanting to look and see exactly where that cancer went to help surgeons in planning. And we can see that it's involving the muscle right here. So you can see that it's extending all the way to the muscle, and that's enhancing. So then we know that some of the muscle needs to be taken. This is just an implant rupture. We can see these curly cues throughout here indicating that there's been a rupture that you can't see other than by MR. So we're going to talk a little bit about high risk subgroups. The ACR had a nice paper come out in 2017 about this, and it's really helpful for people to understand who could be at high risk because it helps you to be proactive and to be able to seek help if you are high risk. Patients with genetic mutations are high risk. BRCA1 and BRCA2 are the most common genetic mutations that we hear about, but there's several others that I have listed here. Certain women of certain demographics are more likely to have high risk mutations, and one of those are Ashkenazi Jewish women. They're much more likely to have a BRCA mutation. Also, women with a strong family history. So it's very important to ask our patients about their family history and to kind of know your family history. If people in your family have gotten breast cancer early, these are things that you really want to be aware of. Also, people who've had chest wall radiation for treatment of lymphoma, they're at risk for breast cancer if they had it before age 30. If you've had a personal history of breast cancer, you're at risk for future breast cancers in the other breast, especially when you had it when you were young. And then patients with, if you had a biopsy and they said it's not cancer, but it's kind of high risk, then you're at some degree of risk. And additionally, people with dense breast tissue, they are at slightly higher risk. So if you have extremely dense breast tissue, you're at 4 times the risk of somebody with fatty breast tissue. And we'll talk about that in just a second. So, African American women, we talked a little bit about the disparities and the mortality rates with that. And Black and white women actually have the exact same occurrence rates of breast cancer, but they're 19% more likely to die of their disease. And we spoke about this earlier. Um, and they're also less likely to be diagnosed with stage 1, but twice as likely to die of early cancer. So a little bit of that is tumor biology. Um, the BRCA gene mutation that we just talked about is more common in African American women, and in African American women that have breast cancer, when they go and test them, it's much more common than in white women to have that BRCA gene. And the problem with that particular gene is that the cancers that are associated with it are very aggressive. Additionally, African American women are more likely to have a subtype of breast cancer called triple negative breast cancer, and those are much more aggressive than some of our other cancers that have hormone receptors on them. So we talked a little bit about density and briefly earlier, and I want to talk just a little bit about why being dense matters. It does increase your risk. That tissue is more active, more likely to have breast cancer in that tissue, and it makes it really hard for us to see breast cancer. Our mammograms are very limited for these patients. So tissues rated A to D, with D being extremely dense. And Georgia began reporting this in July of 2019. So all of you may have had a letter, or the ones that are dense had a letter that came out that said, hey, you have dense breast tissue. This is just a slide of that. So this is a patient that has extremely dense breast tissue, and this is a patient that has fatty breast tissue. So, and these are in between, and I'm going to show you why that matters. The reason that matters is this is the patient with dense breast tissue. Everything is dense, and this is her cancer, and it's incredibly hard to see. So she's feeling this, and we were able to ultrasound it and see it and realize what was going on. But as you can see, it makes reading a mammogram really hard. This is just an example. This is somebody with fatty breast tissue, and she's got this teeny tiny cancer, and we can see it super early. And this is somebody with dense breast tissue, and you can see the breast tissue, other than the fatty border right here, you can't even tell the difference between the cancer and the breast tissue right on this side, because having dense breast tissue obscures cancer detection. So this is a 2015 map of all the states that were requiring the mammo centers to report breast density to patients. And the reason they were required to report it is so that a patient would know if they had dense breast tissue that they might need supplemental screening, or they might need just to be really aware if they felt a lump, they needed to go back in. And then this is a map in 2019. So you can see almost every state is now requiring reporting. But in 2019, the steps were put forward to have a national notification, and that's not done completely yet, I don't believe. But we're in the process that the entire country will be notified of their breast density after a mammogram. So, what should you do if you have dense breast tissue? Some things that we talked about: tomosynthesis, which is what we do at Emory for everyone, and that's great. MRI and screening ultrasound, contrast mammo, and something called molecular breast imaging are what we're looking at. So, screening ultrasound is good in that it finds small invasive cancers. It doesn't find a lot of them, around 3 to 4 per 1,000 women. But the problem is that right here you can see it really increases recall rates and unnecessary biopsies also. And it's very time consuming and can also be operator dependent. This is just a picture of an automated breast ultrasound, and you can see these different hypoechoic areas within the breast, and it kind of shows everything at once. Contrast mammo actually has similar sensitivity to MRI, and it's been proven to be very helpful for women with dense breast tissue. You can delineate things with that, and it's a little bit less expensive. There are some issues with it. Contrast is tough for people that have kidney failure issues with that, so you have to be very careful in screening. But it's definitely a good test. So this is a patient that has a breast cancer right here, and you can see that breast cancer. And when you subtract out the thing you can't see on this mammogram is the fact that she has another breast cancer right here. But this cancer took up the contrast. It's very similar to MRI in that it takes up the contrast. The downside is that it's a lot of radiation. So contrast mammo has more radiation, MRI does not. But any supplemental screening modality has some drawback. So this is a picture of an MRI, the one that I showed you earlier, and as you can see, you it's not limited by tissue density. You can see things enhancing. It's the gold standard, but the problem with MRI is that it's expensive, and that patients are known to have gadolinium deposition. So the contrast agent that they use for MRI has been shown to deposit in people's brains later. They haven't really said that it causes any problems, but we know that it is there. And I don't think that anyone knows for sure what that's going to mean long term. Additionally, what we do at Emory right now is something called abbreviated MRI, and it's a 10-minute MRI. We're able to do that at a reduced cost. And that's something that takes up the abbreviated MRI takes up contrast, doesn't give us tons and tons of information, but it at least sees through that dense tissue, and we can say, oh, this area is abnormal or this isn't. Molecular breast imaging is another thing that we can use. All of these modalities have the same thing. They get through the dense tissue, and they use something else besides a mammogram. And this is the same thing, but this one uses technetium sestamibi, which is a radioactive tracer. And the problem with this is that there's a lot of whole body radiation. So for this to be super helpful, they're going to need to reduce the whole body radiation, and they're also going to need to have better cameras so that people aren't exposed to so much radiation during the acquisition. But it's a great test. This is the mammogram where we can't see any cancer, and then here you can see the cancer out here after the administration of the technetium sestamibi. So these are just the supplemental screening methods, and they all have pluses and minuses. MRI is currently considered the gold standard. It'll detect about 14 per 1,000 cancers in a high risk population, in addition to what mammo sees. None of the other modalities offer any benefit over MRI, but we do need to think about cost and things like that, and contrast CT is very good with that. So that's just a summary of the recommendations. And then I'm going to talk a little bit about why we have so many recommendations. Um, and that has to do with the United States Preventative Task Force. It states that women should have mammo beginning at age 50 and ending at age 75. Um, and it says that women who place a greater value on the potential benefits versus the harms can begin screening at 40. Um, so it's kind of up to you, they say. However, we always worry that insurance won't cover screening at 40 if it's not if it's not recommended with the task force. The harms are false positives. There's a chance that you'll get called back and not have cancer. There's also a 2% chance you'll need a biopsy. And then there's a chance your mammogram may not detect your cancer, like we talked about earlier. It's limited by density. So there's also a chance that your cancer might not ever cause your death and that you would be removing it unnecessarily. But the benefit is lives are saved. And we talked about that earlier. And 40% of all the years saved are in women in their 40s. So screening at 40 to us, to the American College of Radiology and the Society of Breast Imaging is very important. So American College of Radiology Society of Breast Imaging recommends screening every year at 40 because it saves the most lives. I'm just going to show you a couple of cases about why we recommend that because I know I'm running out of time. So this is a patient that came into Emory Midtown for a screening mammogram in 2011, and she was called back for this little bitty asymmetry, but she didn't come back. We think it was a financial issue, and so she wasn't able to return. But she did come back in 2015 when she felt this mass in her breast. And you can see she has skin thickening. This mass has taken over her whole breast. Everything is abnormal about her breast. These lymph nodes are abnormal. And this is a picture of the mass. It's so large that we can't even get it on one ultrasound picture. So when you're looking at breast cancer, we showed that slide briefly about if it's contained to the breast, and it's certain size and you're stage 1, then you have that, really high chance of surviving breast cancer. But if it's out of the breast, your chances go down a lot. So these are the lymph nodes underneath her other side. Okay. And so this is a normal lymph node, or normal lymph node cortex. And then you can see a huge bulge right here, indicating that she has cancer underneath her other lymph node on our other side, which means it's metastatic. This is pictures from her spine where she had multiple bony mets. So this was what we saw in her screening mammogram. So the natural history of her cancer was from 2011 to become this in 2015, which was metastatic. So if she had come back and we would have been, this very likely would have been curable. We will not know though. And this is why we recommend screening every year, starting at age 40. So I'll show you another case. So the United States Preventative Task Force talks about getting screened every other year, starting at 50. And a lot of the time that's, good, it's adequate, but it's not always adequate. So this is a patient that went from 2000 to 16. She was abiding by those recommendations, 2014 to 16, 2 years. So in 2 years, she went from having a normal mammogram here to having multiple masses here. And on her ultrasound, she actually had 6 breast cancers. And then in her lymph nodes, you can see that she has abnormal lymph nodes. And this is her MRI showing that it's in this entire breast. So we don't know what 2015 would have looked like for her, but we have to think that we would have been able to find it at an earlier stage. So the key points in this talk are that screening mammo saves lives. The best supplemental screening is yet to be determined, and it kind of depends on you and what you're looking for. And that the most lives are saved with a mammo starting at every year.